Tuesday. At this point, I'd like to introduce our speakers, both with North Mississippi Health Services, President CEO Shane Spees and Chief Medical Officer Dr. Jeremy Blanchard. At this point, I will turn it over to Shane and Jeremy.
Thank you. Good afternoon to all, and appreciate the opportunity for us to share with you today just a few minutes of 2-month-long experience with COVID-19. Before I introduce you to and turn it over to Dr. Jeremy Blanchard, thought I'd share with you how we've organized our comments today. Dr. Blanchard has, of course, been with us since December of 2019. So he took over when Dr. Dick White retired at the end of 2019. So we're pleased to have Dr. Blanchard. Dr. Blanchard has been the lead of our command center since we began our preparations for COVID-19 and also activated our operational changes. So you certainly will want to hear from Dr. Blanchard and share our experience with you. Before I turn it over to Dr. Blanchard, I just want to send out a huge thank you and appreciation to the community, to you all here on the call for your significant support to our healthcare team over the last couple of months, whether that's been providing food to the staff, providing hand sanitizers. We've had a number of companies provide us with masks and gloves and all sorts of protective equipment. And so for that, we thank you. We hope that you'll continue that ongoing support and know you will in the Tupelo Spirit way. But first of all, let me just say thank you for your generosity during these times. And so I'll ask Jeremy, Dr. Blanchard, to share our clinical experience with you. Then I thought I would wrap it up by sharing with you just a business overview of COVID. So with that, I'll literally hand it off to Dr. Blanchard.
Good afternoon. I'm Jeremy Blanchard. Thank you for having us, and I look forward to your questions as well. I thought I would break up the conversation for us with a little bit of a timeline, our present situation, and then go into a little bit of an analogy about testing, because I think it's one of the most complex and difficult things to understand as part of this whole process, and then talk about our future situation and then some lessons learned. And it'll take about 10-15 minutes to go through that. So the first case appeared in the United States on January 19th, 2020 in Snohomish County, Washington State, which is pretty significant for me individually because my daughters live in Washington, one in Seattle and one in Ellensburg. So it was real here, and it was really in my wife and my hearts as we have moved to Tupelo. On February 21st, we stood up our first COVID-19 safety huddle group, which then evolved into an incident command center and progressed to daily updates each morning. On the 10th of March, we opened our first drive-through clinic at the Brunson Clinic near our main hospital. On March 14th, we admitted our first person under investigation and opened our COVID-19 cohort unit, which continued to expand 1 floor, then to 2 floors. On March 31st, we began our COVID community hospital safety huddle. And this was instrumental for us to go along this iterative approach because, as you'll hear in a minute, we actually developed a model that allowed us to contract and expand as needed. There's actually 3 groups of surges that take place in a setting like this. There's a surge of intensive care unit patients, there's a surge of non-intensive care unit patients, and then there's a surge of patients that were afraid to come to the hospital and waited until an elective or a needs to be done in the near future issue becomes an acute issue that has to be addressed immediately and emergently. On April 6th, we went to universal masking. The key to the masking, which mine is right here, we took it off for these presentations, but and Shane's wearing his now as I present. But what universal masking does is it stops us as asymptomatic folks from spreading to others. When you see somebody wearing a mask, they may think they're doing it for them, but they're really doing you a favor. So when you wear a mask, you're doing others a favor, and you also are decreasing your chance slightly, but you're more so decreasing their chance of giving you something if they're wearing a mask, or you're decreasing your chance of giving someone else something if you're wearing a mask. On the 9th of April, we managed our first COVID-19 person of interest and created that systematic expansion contraction that allowed us to have, and this is a little bit of a confusing number if you ever read it. We normally have 50 ICU beds, 30 of which we actively manage. But we created our 5th and our 4th floor in one of our towers because we can change the way the air flows. We changed those to ICU compatible beds. So at one point, we had 88 ICU compatible beds on our 4th and 5th floor. We had 50 in our ICU, and we were prepared to expand to 20 ICU beds in our surgical PACU, which is sort of your recovery from surgery area, so we could take care of non-COVID patients there to protect them. We also had available non-COVID space, and then within our rural hospitals, we developed 6 other COVID units for patients who didn't require ICU care but could be managed there in negative air pressure rooms. That's really important because that's how we protected our staff, and I'll share those numbers in a moment. And then on April 14th, we began to screen all April 24th, we began to screen all surgical personnel. And our thought is how can we assure you as a community it's safe to come back to our hospital, and how can we assure our folks who are doing surgery it's safe to do surgery? So we also initiated at that time a testing program for all patients with high risk of aerosolizing procedures. And those include like tonsils or things like that. They also include things like laparoscopic surgery because carbon dioxide is used. I'm not sure. It's got something popping up here, Shane. Can you still hear me?
Yes.
Okay.
Mhm.
And so with laparoscopic surgery, we actually pump carbon dioxide in, and then it has to be siphoned back out. So those patients also were getting appropriate screening testing. And then the last group were robotic surgery patients because of the same issue. The carbon dioxide expands the belly up, so it creates a space so they can see inside of that hidden area where they're operating on a gallbladder or something along that sorts. And then on the 28th of April, we resumed our first elective surgery case since March 14th. And that was within alignment with the Dr. Dobbs and the Mississippi State Department of Health's saying that if you had appropriate personal protective equipment, as well as could provide a safe environment, you could begin to do elective surgeries. So working with our physicians, our surgeons, we were able to really look at how we could do this safely. So I want to give you a few numbers. I don't want to overload you with numbers. I definitely have a lot at my hands if I chose to, but I'm going to try to give you some really significant ones. So we have 7,125 employees. And of those employees, 6 of them have developed COVID from a work site exposure. 46, and this was in the system as of April 23rd, and I'm using that date as a common date for when I collected information. So if you look at that, that's 6 out of 7,125, that's 0.08% have contracted COVID in a workplace exposure. 46 employees have contracted COVID from a community exposure. I would say that it's safer, definitely, I wouldn't even say it, I'm sure it's safer to come to our hospital than it is to go out anywhere in the community where there are other people that are gathered. And that's a huge part of what we committed to do, was to create a safe environment for our patients, for their families, and for the employees. Now, how have we done that? So let's go to the present situation. So from a safety standpoint, we've exhibited best practice. And so we have some things that others may not. We have state-of-the-art cleaning. That's key. It's a thing called BioQuil, which is vaporized hydrogen peroxide. Allows us to clean a room. It even allows us to clean masks for reuse, which we haven't had to reuse any, but we have a stockpile of those just in case we needed to. And then we also use herbicide, which is an ultraviolet form of cleaning, which again does very similar to the vaporized hydrogen peroxide. We continue our restricted visitation. This one probably weighs on my heart and Shane's heart the most. Having had a mom who's gone through hospice and a father-in-law and a mother-in-law who also have died within clinical settings, it's incredibly hard to know that we're limiting visitation, but we also know it's essential to achieving those safety numbers that we have. And we hope with time that we'll be able to remove those burdens as we go along. We've done so a little bit with the surgery patients. With an elective surgery patient can have one designated visitor. And we also honor that in end-of-life situations and hospice situations, where a hospice patient or an end-of-life on the COVID unit can have 2 designated visitors during that acute period of time. But these continually change as we try to respond to the challenges of this situation. And then we continue universal masking. We have adequate personal professional equipment or personal protective equipment to be able to do our elective surgeries and manage a surge. Most recently, we've handed out a silver and copper impregnated mask, which you'll see on Shane when I turn it back over to him before he takes it off. And we've given those to every single employee in the system as well as board members. And then we've managed to maximize our virtual care as well. In 2019, we had 5,500 virtual visits. In the first 3 weeks of the COVID experience, we had over 4,000 virtual visits and patients being served in that manner. And what's really interesting to me about that is we've been doing a series of updates for all of our providers, 2 or 3 a week. And then we also created a dialogue called the Fireside Chat after FDR's Fireside Chats. And it has usually 3 speakers or 3 series where they're 15 minutes apiece. But we had Dr. Crosswhite and then Dr. Proda. Dr. Crosswhite's family medicine, you may know him and may even be your physician. And Dr. Proda is behavioral health. They both came on at separate times and shared how fulfilling for them and for the patients and how surprised they were at that fulfillment to be able to have that virtual connection. It allowed them to see the patient in their own home. And sometimes they had to have their grandsons help them out, but it was really special to hear that feedback. I wanted to take a moment to talk to you about testing. So you're going to are hearing and are going to hear a lot about testing. So I wanted to use an analogy. So my last name is Blanchard, and there was one of us that came over on the Mayflower, and then he created a lot of smaller Blanchards along the way, and we're spread across the nation. I grew up in Montana, actually. And so I have 2 daughters and a sister that are direct blood relative Blanchards. And the way to think of testing is like this. So we have 2 different types of antibodies that can be tested for. One is called IgM, and that turns up very quickly in an illness. And then 4 or 5 days later in COVID, a second one is IgG. And people want to test for that antibody because it shows that you have been exposed to COVID. The challenge is COVID is a coronavirus. So here's my analogy. So my name's Blanchard. Let's say that we wanted to figure out where my daughters and my sister lived. So we took all of North America and we collected every single Blanchard. So that would be like we did an antibody test looking for every single coronavirus that had been speciated. So let me take you back. So every coronavirus has an IgG when someone is exposed to it that forms. And the problem with our antibody test is they haven't figured out how to just check for our one COVID virus. So they're checking for all Blanchards or all coronaviruses. And then we wanted to look for those specific 4 Blanchards. One lives in Canada, 2 in Washington, and then I live here. And so what we'd have to do then is we'd have to do something very specific. We'd have to ask, are we related? And what we do is we do that with what's called a PCR test. So we do the antibody test to screen for exposure in our staff and in our high-risk patients, as I discussed. So we look for Blanchards with all of those. When we find a Blanchard, we want to see if it's real or if it's false positive. Was it another coronavirus possibly? Or maybe they were affected by COVID, but they're no longer infected. And so with that, then we do the PCR. So we have tested over 324 surgeons and surgical staff so far, and we can't test all of them at once because we have limited resources, and each week we try to get more tests. But we've checked 324 Blanchards, and of those, only 1 was related to the COVID-19, was PCR positive. So again, we feel like we have an incredibly safe environment. And then what is our future situation? It's to continue this testing so we can go through and try to assure the community and our teammates that were COVID-free, and then address those who might be still shedding the virus if they had been exposed. Second thing is to continue universal masking and the PPE, or the personal protective equipment. We'll continue to monitor that and manage that, as well as our visitation policy. And then in May, end of May, we get another analyzer that we've ordered, which will allow us to do over 1,000 tests a day. Now that'll be limited a little bit possibly if we have enough swabs, because that's the low piece of material right now, a special kind of swab for doing this study. And then we'll resume other elective surgeries as the governor provides us that insight with Dr. Dobbs, and that'll include endoscopy, which we expect to start soon. We'll continue our virtual care. And then lastly, before I turn it over to Shane, I wanted to share lessons learned, and then we'll answer questions. So the big lessons for me have been a few. One is the power and courage and integrity. Sorry. Of our frontline caregivers. I can read the rest. I got it. I recovered. Sorry. The strength of the community and the commitment to collaboration with our team. It's been incredible. One day we come out and a church is honking their horns. Another we come out and there's people singing. The power of the Tupelo spirit. It's real. It's really hard to apply scientific thinking to a problem that has not been scientifically defined. In the end, you have to commit to the best decisions and prepare to respond to information that requires changing or adapting. The power of model application. Shane has a great saying he may pick up from another of his colleagues that says, no model is right and some models are helpful. Boy, have we seen that. And people speak from an authoritarian point of view about models when they really shouldn't. We've learned that too. Power of systemness. It's amazing the power of systemness that we've been able to tap into. Communication, the cadence, the monologue, the dialogue, the mindful listening, and external and internal communication. And then a pandemic is just not a medical challenge. It's an economic challenge that looms large and long. I'm going to turn it back over to Shane. Thank you.
Sure. Thank you, Dr. Blanchard. Let me remove my mask so you can hear me okay. And so clearly, from Dr. Blanchard's talking points and the emotions, it's been a long journey over the last couple of months. And keep in mind that Dr. Blanchard, along with many others, have been living and breathing this 24/7 for the last 2 months. Fortunately, the outbreak didn't turn out as large or prolific as the models predicted. And as Dr. Blanchard said, we view all models with skepticism because all models are wrong. Some are useful. And so we did utilize modeling to help us forecast the potential volume of patients, as well as when we might expect to see a surge in number of patients. But if you were to look at our trend line of actual COVID-19 patients, or patients that we suspected had COVID-19, you would see that we reached our peak in those volumes in the second week of April. And then starting after the second week of April, began to trail down our decline in volumes. Up until the present time, they continue to decline. So we're happy to see that. However, as Dr. Blanchard pointed out, we continue to keep the same safety precautions and safeguards in place all across our entire facility. We are excited that we're able to restart a number of elective procedures and surgeries, including some cardiac procedures as of last week. In talking with our state leadership as recent as Friday, we're hopeful that we could open up to include all elective and non-essential visit types after May 11th. That came directly from Dr. Dobbs. Again, that was his hope or sharing optimism. And so we'll keep a watchful eye on that. So hopefully we will be able to offer any and all elective and non-essential visits after May 11th. I just want to touch on a couple of points taking away from Dr. Blanchard's final comment. I've mentioned in the newspaper our the business challenge that this has presented for us, like it has for all of you and your businesses. And so if you think about the timeline that Dr. Blanchard shared, we saw our first COVID-19 patient on March 14th, excuse me. Literally, it was like a light switch was flipped from on to off in terms of volumes throughout our system. Within a 2-week time frame, our volumes declined some 40 to 60%, depending upon specific area. And it has, up until last week, stayed at that lower level since the beginning of March 14th. We are seeing those volumes gradually come back, and we're hopeful that they'll come back sooner rather than later, not just from a business standpoint, but from our healthcare standpoint, from our community healthcare standpoint. Because you have to keep in mind, we have a number of people in our communities that have a number of chronic conditions that have to be managed on an ongoing basis, if not day to day, week to week, and month to month. So we know, based on statistical information, that a number of those folks, in fact, over half, are deferring health care to some time later. And for many people, that's not good. And it's not good medicine or not good health care. So we hope by sending out the messages and providing talking points on how safe we are, hopefully will reassure the community that it's safe to come back and utilize your healthcare facility, whether it's a hospital or a physician's office. And we do know that the community is interested in coming back to seek healthcare, but we do expect that to be a gradual process that will take months. Question is whether it takes 2-3 months or perhaps 6 months. That's a big question as of now. Fortunately, we've been able to right-size the cost operations during this interim period, and we've also received from federal relief funding as part of this. It's not as large as you may anticipate or expect due to some numbers you've heard in the media, but we have received some federal relief. We expect to receive some additional federal relief in the next week to 2 weeks. And I'll end with this comment that thankfully we had a very healthy balance sheet coming into this pandemic, which will help ensure that we come out of this with some financial health and allow us to recover financially faster than, say, other hospitals or health systems that entered into this pandemic with a weak balance sheet. So we're optimistic that we're going to get out of this in a matter of several months, and that we'll have a quick recovery, both clinically and financially as a healthcare system. So with that, I'll take a pause and see if there are any questions from the group.
By the pot on the right.
All right. All right.
I'm sure it'll be at Brandon's in a little while.
I have a question.
Sure.
Hey, this is Greg Herkel. I have a couple of questions too, actually. Number one, is there any development of a type of test that can test to see whether you have it? We're all seeing the thing shoved up your nose and it looks, and while it might be, that should be fine. Is there another type of testing that's coming out that maybe is a little less invasive? And then secondly, we'll go ahead and answer that one. And then the next one comes, how likely is this to happen again? I mean, this can't be something we do every year. We can't do this every COVID season. So what can be done to slow the spread but not shut the economy down?
Yeah, so thank you for the question. So the first question is where are we at with evolution of testing to different types of tests? So you're correct. The polymerase chain reaction is the one that comes from the nasal swab that has to put very deeply into your nares or your nose hole. And the second testing is the antibody testing. That's a blood test, but unfortunately, it's not a very good test yet. It has a lot of false positives. A lot of Blanchards or a lot of coronaviruses are picked up in that regard. Abbott has a test that's done with a finger stick, but its sensitivity is so-so, which means that if you had 100 people with the disease and you checked them with that test, 85 would check as positive, the other 15 wouldn't. So the problem is that's not a realistic test right now. They're looking at one that can be done like a pregnancy test, but they're having issues with the shedding of the virus. So the testing is an important part of it, but more so to look at, probably in the end, it'll look at prevalence in a community rather than, just identifying if you have acute infection. Because if you have a low prevalence, then when there is a case that is positive, then what they'll do is they'll look at everyone that's in contact and they'll isolate them. That's what that contact mapping is that you're hearing about. Now, your second question was, will this happen again? I just was reading an article on that, there are over 500 coronaviruses that have been discovered in bats in China, and that the average villager will get has antibodies to different types of coronaviruses. SARS was a coronavirus, MERS was a coronavirus. So it will happen again. The frequency of it will probably be somewhere in 5 to 7 years, to 10 year kind of thing, but nobody knows that for sure.
Our meeting will end in about 50 seconds.
Shane, this is BB Hodge. I don't have a question. I just want to say that you and David and Jeremiah and the team there, thank you for your leadership and for being there when we need you.
Thank you for your support and the community support. We greatly appreciate it. I hope those comments were helpful.
Real quick, Shane, is there anything we can do? I mean, I know that's a broad question, but.
No, I think it sounds like it's Amanda or perhaps Jeannie, but yeah,
It is Amanda.
We still have an opportunity for folks throughout the community to make donations and contributions to us. You can go to our website and look at the COVID update page, and we have information on how to contact us and drop-off sites. So again, our staff has really appreciated the food that's been donated for them. We also are still accepting personal protective equipment, although we have a really nice, good inventory, as Dr. Blanchard mentioned. So, and continue your thoughts and prayers. Most importantly, continue your good hand washing. Continue your social distancing. Continue avoiding large group gatherings. And the masking is important, as Dr. Blanchard mentioned, not so much to just protect you, but to protect those around you.
Thank you, Shane and Jeremy. And Jenny says we'll be running out of time shortly. So thank you for all joining. Thank you.
Thank you very much. Have a great week.
Thank you all.